So in this video, we'll cover some of the most common clinical measures of associations, such as relative risk and odds ratio, sensitivity, specificity, positive and predictive values when we're evaluating the accuracy of a diagnostic test, as well as positive and negative likelihood ratios. So if you viewed any of my videos on statistical analysis, specifically in research methods, the majority of the tests that we have run thus far has dealt with data or numbers that is continuous or scale in nature. We can add, subtract, and we can calculate the average, the standard deviation, the variance of BMI, VO2 max, valgus torque, whatever it may be. But as a clinician, more often than not, you run into categorical data, right? Injured versus non-injured, male and female, non-athlete versus an athlete, positive, negative. Those are examples of what's known as categorical data. And that type of categorical data involves a different set of statistical analysis that's slightly different from some of the other parametric stats that we've done thus far, because they're categorical in nature. And no other field is that type of data, categorical data, most prevalent, I should say, in the field other than epidemiology and diagnostic testing. So before we get into relative risk and odds ratio, I just want to give you a quick review on the difference between the incidence of an injury or incidence of a disease versus prevalence. Incidence is the number or proportion of new cases of, and I put down here mortality, morbidity. That's just fancy words for saying injury or disease. And so in the context of our field of kinesiology, we'd be maybe looking at ACL injuries or looking at shoulder injuries. In fact, the examples I use in this video involve the knee and the shoulder. Prevalence is the total number of cases. So although they mean similar things, prevalence is the total, incidence is the new number of cases of that injury or disease. So I'm going to use COVID-19 as an example because it's at the time of the recording of this video, it is both prevalent and relevant to the discussion here. So I'm going to use the Johns Hopkins dashboard to illustrate the difference between prevalence and incidence. Okay, so I have here the prevalence and incidence of COVID-19 cases within the last 5 months. This is a 5-month period, and you can unfortunately see that the total number of cases has increased the last 5 months. That is prevalence. That is an example of prevalence. Where this line right here is the new cases per day. So that is the daily incidence of COVID-19, and some dashboards or some sites like our county of San Diego will display both prevalence and incidence, and the incidence may be a moving average where they're taking the average of 14 days or 7 days. So at the time of this video, or the recording of this video, the incidence in the San Diego County for COVID-19, I believe, is at 4%. So we want that number low. We want it obviously below 2% or 1%, so that we can get that total prevalence, the prevalence of COVID-19 in our county, as low as possible. So anyway, that is an example, perfect example that illustrates the difference between prevalence and incidence. So in that context, and we're talking about epidemiological measures of association in this case, there are two measures of risk that we use, or most commonly used, to determine the relationship between certain risk factors and disease or injury. One's called relative risk and the other one's called odds ratio. And the relative risk is literally a ratio of risk in a group that is exposed to a risk factor versus the risk of an unexposed group. So let's just say the risk factor is cholesterol, and you want to know what's the risk of a group that is has high cholesterol and develops cardiovascular disease versus the one that's unexposed to the high cholesterol. So we take the ratio between two. That's called relative risk, and that is something we use in longitudinal prospective studies if we were to take a group of patients and distinguish them by their cholesterol levels and just follow them over time and determine the incidence, in this case, of cardiovascular disease, I can calculate the relative risk in that scenario. Odds ratio is slightly different. It means the same thing, but it is an estimate of risk used in prevalence studies, more specifically case control studies. So this is something that you look back retrospectively. You retrospectively examine data that you have. So you have a set population, let's just say ACL injuries, and you wanted to know whether or not they wore knee braces or whether or not they perform a certain exercise. So that is an exposure, the exercise or the intervention, and the condition or the outcome would be, in this case, knee injury. So if I measured the odds of someone having a certain factor that would lead into that outcome versus the odds of someone who does not have that factor but still came up with the outcome or not, take the ratio of the two odds, is called an odds ratio. And the way you calculate odds, odds and probability are related, and I like using a coin flip, for example. You know that there is a 50% probability of getting heads or tails. So the odds of getting heads to tails, or heads or tails, is 1 to 1 because it's 50 to 50, and that's how this is the relationship. This equation shows you shows you how you calculate odds from probability, right? So 50-50, 1 to 1. Okay. All right, so that in mind, let's use or take a look at probably the most common tool that we use in categorical or analyzing categorical data, such as risk factors, relationship between risk factors and disease or injury. So this is the contingency table, and we could categorize patients based on whether or not they're exposed to a risk factor, as well as whether or not they develop the condition. And keep in mind, I put here exposure, and I keep saying risk factor, and that could be any factor that either increases or lowers the risk of that individual of getting the condition. So it doesn't necessarily mean a bad thing. Okay, so you've got here 4 cells. Cell A here is the group that is exposed to a risk factor and they ended up getting the condition or disease. Cell B is the same group that is exposed to it, but not the same group, I should say, but it's another subgroup of the exposed population or sample that did not get the condition or the disease. C here represents the unexposed group, or these are people who do not have the risk factor but develop the condition anyway. And D right here represents another unexposed group but also did not get the condition. Okay, so let's use this contingency table setup to calculate relative risk. Recall that the definition of a relative risk is the ratio of risk of those who are exposed to a factor versus those who are unexposed to that risk factor in developing an injury or a disease. So in this study, I've got a prospective study of 200 athletes, and we followed them over the course of the season, and then I wanted to know as a clinician whether or not warm-up influenced the incidence of ACL injuries. So I found out at the end of the season, 41 athletes had confirmed ACL injuries, while 159 of them were non-injured. And these are the numbers for these cells in the contingency table. 14 in the warm-up group were injured, while 86 were non-injured. And in the non-warm-up group, they were 27 in the ACL injured group, and 73 of them were non-injured. So we'll calculate the risk or the ratio of risk by calculating the risk first in the warm-up group. So that would be 14, put it here, divided by the total in the warm-up group. That's 100, so that's 14%. And you do the same thing for the unexposed group, the non-warm-up group. That would be 27 divided by 100, because there's 100 in each group. So that is a risk of 27% in the non-warm-up group. Take the ratio between the two, and what do you get? How much does warm-up use decrease or increase the risk of an ACL injury? Correct. The relative risk is 0.52. What this means is that warm-up reduces the risk of getting an ACL injury about half, about 50%. So that is the relative risk, in this case, of an ACL injury if the person were to either warm up or no warm-up. Notice here that the relative risk decreases because it's 0.52, indicates that warm-up decreases the risks of an ACL injury. Okay, so let's take a look at another example using the contingency table to calculate odds ratio. I've got here a retrospective study now, and I'm looking back and comparing a group of cases. It's actually called a case control design. So in this case, the case is ACL injuries. So I've got 50 athletes with ACL injuries and compare them to 50 controls, and I wanted to determine whether or not knee brace use lowers the odds of someone getting an ACL tear. So I'll run the case control analysis using the contingency table to calculate the odds ratio. So the odds of knee brace wear of getting an ACL injury is given by 21 over 29. That is the number of injured ACL athletes that wore a brace versus the number of those who did not wear a brace. So that's 21 over 29. And then you do the same thing in the non-ACL injury. This is the control group, so that is 37 over 13. Take the ratio between the two, answer this question. How much does knee brace use decrease or decrease the odds of an ACL injury? Cool. So if you got 0.25 or 25%, that is correct. You're saying that the odds that an injured athlete wore a brace is a quarter of that of a non-injured athlete wearing a brace. So in other words, if you were to wear a knee brace, the odds of you getting an ACL injury in practice or in a game is a quarter of that of someone who does not wear a knee brace, right? Makes sense. So now, the last two examples with relative risk and odds ratio, I just gave you one number, and so it doesn't really tell us whether or not we can apply or expand that number, or I'm sorry, extend that number to the general population. So one way we can use this is use confidence intervals. So I've talked about 95% confidence interval in my previous videos on where it includes the range of values in which the population parameter most likely falls. So we can use that same interval to describe the quote-unquote statistical significance of a relative risk or odds ratio. So it is a measure of precision. The null hypothesis when we're talking about a relative risk or odds ratio is 1, because a relative risk ratio or relative risk of 1 means that there is no difference, or there is no change in the outcome whether or not they have the factor, whether or not they're exposed to a factor. There's no difference in the odds of getting the outcome whether or not they wear a knee brace. So the null is going to be 1. So if the 95% confidence interval does not include 1, then we can be 95% confident that the true value, whether it's the relative risk or the odds ratio, falls within that interval. One thing about these 95% confidence intervals is not something you can calculate by hand or using Excel, so we have to use a statistical software such as SPSS or SAS. But in this example, I'm going to use RStudio to calculate the 95% confidence interval for the relative risk and odds ratio for the examples I showed just a few minutes ago. Okay, so now I'm back in RStudio. I'm going to load the necessary package that is needed to run a number of different categorical based statistical analysis, such as relative risk, odds ratio, chi-square analysis. But in this example, I will be calculating the relative risk, the odds ratio, as well as their respective confidence intervals for the two contingency tables I showed you earlier. One was for the warm-up, no warm-up with ACL injury, and the other one is brace, no brace with ACL injury. That was the case control series. So I'm going to go ahead and run these two lines of code. Oops. I'll run that again. Calculate the relative risk for the incidence study and the odds ratio for the case control study. Remember, for relative risk, we're using that for the prospective longitudinal incidence study, and the case control series I showed you here is for prevalence study. Okay, so if we scroll down here, this is in the console. These are the results. For the relative risk, what we're looking for is the estimate itself. So same thing we found earlier, 52%, and this is the 95% confidence interval from 28% to 93%. And the odds ratio for the case control study shown here, there's roughly 26%. And the 95% confidence interval showed here 11% to 60%. Okay, so if I bring up the relative risk and odds ratio I showed you earlier, this relative risk is the ratio of risk of the warm-up, no warm-up on the risk of the ACL injury. We found that it was 52%, meaning a player who warms up has about half the risk of an ACL injury that of a player who does not warm up. And we found that the 95% confidence interval for that contingency table was between 29 and 93% because that interval does not include a relative risk of 1, which is the null hypothesis. That means that the risk is the same whether or not they warm up. We can reject that null hypothesis and conclude that a relative risk of 52% is statistically significant. Likewise, for the odds ratio, we found it was 0.25. That means that the odds of an injured player wearing a knee brace is a quarter of a non-injured player wearing a knee brace. Makes sense, right? That you're wearing a brace, you have a greater chance of not getting injured. I should say a lesser risk of getting injured. The 95% confidence interval for that odds ratio is between 11 and 60%, or 0.11 and 0.60. Again, because it does not include the odds ratio of 1, we can conclude, we can reject the null hypothesis and conclude that the odds ratio of 0.25 is statistically significant. So another example of analyzing categorical data is through testing the accuracy of diagnostic tests. So if you're a clinician, an AT, physical therapist, OT, orthopedic surgeon, you know a number of field tests that we use in a lab or clinic to indicate whether or not a patient or athlete has an injury. And we confirm the existence of that injury by sending off to get an x-ray or sending off to get an MRI. So if we stick with our knee injury example here, looking at ACL, I'm going to look at the Lockmans, right? When you do a Lockmans test, you either get a positive or a negative. You get a positive, that gives you the suspicion that someone has an ACL tear or some related injury, and they then send off and get an MRI that confirms it. So that field test is compared to that criterion, in this case the MRI, to determine how accurate that test is. And there are a number of statistics that we can measure off the results of those tests using the contingency table, and it's pretty straightforward here. So I'm going to use the Lockmans test. And the setup of the contingency table is very similar to what I did with the relative risk and odds ratio, is that we're put here in the columns whether or not the condition exists. In this case, condition means injury, ACL injury, present in this column, and then in the second column is no injury. And in the rows here are the results of the test, either positive or negative. So the cells A, B, C, and D can be used to calculate sensitivity, specificity, positive and negative predictive values, and subsequently the positive and negative likelihood ratios, which I'll go over there in details here in a sec. So let's take a look at the Lockmans test. Here are some examples where there are, looks like we have 100 injured players in our sample here. This is ACL injury, and also 100 of the non-injured players. These are the results of the Lockmans. So 80 of the injured players were tested positive, and 20 of the injured players tested negative. While 45 of the non-injured players tested positive, while 55 tested negative. So we can calculate the sensitivity of the Lockmans test, which is the proportion of the injured players that tested positive. So it is the rate of true positive. And that is calculated here by the cells. So this would be A divided by A plus C. So that's 80 divided by 100. Do the math. You can probably do this in your head. That is a sensitivity of 0.80 or 80%. Right? Makes sense. Now let's take a look at specificity. How specific, or what is the level of specificity of the Lockmans test? So this is the proportion of all the patients without the condition who tested negative. So is the rate of true negative here. That's the second column that I show you here. So that is 55. D divided by 100, so that gives you a specificity of obviously of 55% or 0.55. I think those of you who are experienced clinicians know what this cell here, which is B, and this cell here, which is C. B, this is 45. These are the number of patients or athletes who had a false positive, right? And whereas these people here, 20, these are the number of people who have got a result of a false negative. Good. All right, so that's sensitivity and specificity. Another statistics that we use in testing out the accuracy of a diagnostic test is the positive predictive value. That is the proportion of all the positive tests who have the condition, who actually have an ACL injury. So this is 80 divided by the sum of 80 plus 45, so that's the probability of a patient with a positive test actually having the condition. So in this case, that is a positive predictive value of 64%. That means 64% of all the positive tests tested positive. Probability of a patient with a positive test having condition, having the injury. Negative predictive value, as you can imagine, is the other way around. It's the probability of a patient or an athlete with a negative test actually not having the condition. So in this case, this would be 55, right? This is D here, divided by C plus D. That gives us a negative predictive value of 73%. That is the probability of a patient with a negative test not having the condition. So that is a negative predictive value. Now, the problem with using positive and negative predictive values, don't get me wrong, like sensitivity and specificity, these are very useful metrics of accuracy of a diagnostic test, but they're highly sensitive, I should say, pardon the pun, to prevalence of the injury itself. So if you have something that has very low prevalence, for example, you'll have a specificity that's very low. You have a lot of false positives. So as an alternative, likelihood ratios become more in favor in the clinic because of the predictive value, and they're not sensitive to prevalence. And there are two types. There's positive and negative likelihood ratio. A positive likelihood ratio provides the increase in odds and probability of a person having the condition given a positive test result, and is calculated off the true positive rate, sensitivity, divided by the false positive, which is 1 minus specificity. So if you were to get a positive Lockman's test, the probability of the person actually having an ACL injury goes up given that test. Okay, and I'll show you an example in a sec here on how we use the positive likelihood ratio. The negative likelihood ratio is the other way around. It provides a decrease in odds or probability of having the condition given a negative test result, and it is calculated off this one is the false negative divided by the true negative. And if you were to get a negative Lockman's test, for example, the odds of the person actually having an ACL injury goes down with a good negative likelihood ratio. And what's considered good or useful is provided in research. For example, positive likelihood ratio of over 10 is conclusive. It gives you a conclusive shift in probability that you can be confident that the person actually does have an ACL injury if you're doing a positive, if you do get a positive Lockman's test. Conversely, if you were to get a negative likelihood ratio of 0.1, and then there's a shift in probability that goes down, that is a confident conclusive shift in probability given a negative test. So you can calculate these positive and negative likelihood ratio given the contingency table. In fact, the numbers I showed you earlier with the Lockman's tests, we found that the positive likelihood ratio for those results was 1.78, not very good, and a negative likelihood ratio of 0.36. So this means that it's more specific, that it can rule out whether or not a person, it can rule out an ACL injury given a negative test. So there are tons of research out there on diagnostic test accuracy, and they provide the change or shift in probability given the positive or negative likelihood ratio. So you as a clinician can use these numbers in research, and if you're looking at a new test for an ACL injury or to test out a shoulder injury, you look up the research, look up the positive and negative likelihood ratio, and what you can do is calculate the post-test probability that this person actually has a condition. I'll give you an example here. This is from an article that looked at 3 clinical diagnostic tests for not just ACL injuries, just knee injuries in general. So it would be anterior drawer, pivot shift, and the Lockman's test. And what they found for the Lockman's test was that it had a positive likelihood ratio of 10.2. So according to research, the pre-test probability of a person having an ACL injury, just say you're covering a game and a soccer player and they fall or grabbing their knee, you have suspicion that the person has some type of knee injury, whether it's ACL, MCL, and or meniscus. According to research, the probability of the person having an ACL injury is 44%. Don't ask me how they got that number. It's just from the probability analysis that they've done on these injuries. Convert that to odds. The pre-test odds for 44%. You can calculate this using this equation, which is probability divided by 1 minus probability, and the odds is 0.786. You can then multiply those pre-test odds by the positive likelihood ratio, in this case 10.2. That's what I've given here, and that gives us the post-test odds. That means the odds of the person having an ACL injury is 8-to-1, which conversely, if you were to convert that into probability, is 88%. There's an 88% probability that this person has a torn ACL given a positive Lockman's test. That's what the positive likelihood ratio gives you. If you do the Lockman's test correctly, and I'm sure you as an AT, as a PT, have a lot of experience doing this, then you can be confident that, oh, you know what, there's an 88% probability that this person has a torn ACL given a positive test. Now, for a negative test, according to this research article, they found that there was a negative likelihood ratio of 0.2, which is pretty good, given the same pretest probability. 0.786 is the odds, pretest odds. Multiply that by 0.2, the odds of the person having the ACL injury or a torn ACL is 0.157, and convert that to probability. That is 13.5%. That means if you get a negative result on Lockman's, there's a roughly 14% probability that the person has an ACL injury. Cool. So let's try an exercise here. This is a hypothetical study looking at a test for SLAP lesions, SLAP injuries of the shoulder. This is superior labrum, anterior posterior is like weeding of the glenular labrum that a number of overhead throwers and pitchers are commonly afflicted with because of just overuse in the shoulder and the glenohumeral joint there. So there is different diagnostic tests for a SLAP lesion, and this particular test, what the researchers found is that of the confirmed SLAP lesions, these are the athletes with confirmed SLAP tears, 112 of them tested positive, 22 tested negative, and those without SLAP tears, 27 tested positive, and 154 of them tested negative. Given these information, depending on where you're at in this video, calculate the sensitivity, specificity, positive, negative predictive value, positive likelihood ratio, and negative likelihood ratio for the SLAP lesion test, for the diagnostic test for SLAP lesions. So go for it. All right, let's go ahead and check your work. The easiest thing, you can do everything by hand if you like using a calculator, but if you're good with Excel, you can easily do this in Excel. Let me show you here. I set up my contingency table as such. Injury here for the columns, the test results here, positive and negative. And what I did here is I just created formulas for sensitivity, specificity, positive and negative predictive value, positive likelihood ratio, and the negative likelihood ratio using these cells. So I went over this in detail. I'm not going to go over it again, but sensitivity is, in this case, 0.84, 0.85, positive predictive value is 0.81, negative predictive value 0.87, likelihood ratio, positive likelihood ratio was 5.6. Hopefully that's what you got. And the negative likelihood ratio is 0.19. So if you're looking at this, you could see that it has this test for SLAP lesion is fairly sensitive and specific perhaps does not have a high enough likelihood ratio. Remember, anything above 10 is good, positive likelihood ratio. But the negative likelihood ratio would indicate that if you were to get a negative result on this test, that it would rule out the presence of a SLAP lesion.